Welcome back to AJIC Science into Practice, where we dive into the latest infection prevention research and talk about how to make it work in the real world. I'm Nicki, joined as always by my brilliant co-host, Jess.
Hi, everyone. Today we're talking about antibiotics and kids, two things that tend to come together more often than we'd like. The article we're unpacking is titled Identifying Successful Pediatric Outpatient Antimicrobial Stewardship Strategies Through Benchmarking, a multi-institutional project.
And the multi-institutional part is not kidding. So this study looked at over 32 million pediatric encounters across 22 institutions in the United States. That's a lot of sore throats and ear infections and probably a few antibiotic requests that didn't need to happen.
And joining us today are two absolute experts in pediatric infectious diseases and antimicrobial stewardship.
First up, we've got Dr. Rana Feghaly. Dr. Feghaly is a pediatric infectious diseases physician and the infectious diseases clinical director at Children's Mercy, Kansas City. She also serves as the Director of Quality and Safety in the Department of Pediatrics, and she leads the hospital's outpatient antibiotic stewardship program. She's a professor of pediatrics at the University of Missouri, Kansas City School of Medicine, and has spent her career advancing evidence-based approaches to safer antibiotic use in children. She earned her medical degree from the Lebanese University, completed her pediatrics residency in Syracuse, New York, and went on to a fellowship at Washington University in St. Louis, where she also earned a Master's of Science in Clinical Investigation. Dr. Feghaly is board certified in both pediatrics and pediatric infectious diseases, and is an elected fellow of the Pediatric Infectious Diseases Society, the Infectious Diseases Society of America, and the Society of Pediatric Research. She serves on the American Board of Pediatrics Pediatric Infectious Diseases Subboard, chairs the Microbiology and Immunology Committee for the National Board of Medical Examiners, and contributes to several national collaboratives focused on antimicrobial stewardship and health equity. Her research zeroes in on the judicious use of antibiotics and diagnostic testing in outpatient care. And she's led multiple international collaboratives aimed at improving antimicrobial use worldwide.
And joining her is Dr. Matthew Kronman, Professor of Pediatric Infectious Diseases at Seattle Children's Hospital and the Associate Vice Chair for Education in the Department of Pediatrics at the University of Washington. Dr. Kronman's research focuses on antimicrobial stewardship and pharmacoepidemiology. Basically, he studies how antibiotics are actually used in real-world practice, what happens when we overuse them, and how to make prescribing smarter and safer. His work helps identify those unintended consequences that come up from good intentions and turn them into data-driven strategies that can improve care for kids everywhere. Clinically, he divides his time between inpatient infectious disease consultations and outpatient ID clinics, and he co-directs fellows college at Seattle Children's, helping mentor the next generation of pediatric infectious disease specialists. Through his research and teaching, Dr. Kronman has become one of the national voices linking stewardship science to the realities of day-to-day clinical practice and doing it in a way that's thoughtful and impactful.
My goodness, what a duo we've got today, Jess. That's quite a lot of experience we've got. So let's start with the big picture. Why are pediatric ambulatory sites such an important area of focus for antimicrobial stewardship?
So thank you so much for having us today, and thank you for the nice introductions. We're so excited to be here. I'm going to start by, talking a little bit about this because, outpatient ASP is obviously my passion. There's over 85% of antibiotics are actually prescribed in outpatient settings. Both the CDC and the AAP emphasize ambulatory sites as key targets for stewardship program. Yet, most pediatric ASP efforts really still concentrate on inpatient care, leaving all these outpatient initiatives underdeveloped. Even hospitals with very robust inpatient stewardship often don't have a robust outpatient efforts. So if we want to make a real impact, ambulatory care is where we need to be.
Dr. Kronman, anything to add?
Other than saying thank you for having us, and boy, it's an honor, and you make us sound so good. What an introduction!
I think you make yourself sound good. Don't be humble,
right?
I don't know about that. No, nothing to add. I think Dr. Feghaly nailed it.
Wonderful. Well, can you tell us a little bit about the Sharing Antimicrobial Reports for Pediatric Stewardship Outpatient Initiative, otherwise known as SHARPS OP Collaborative, why it was created, and what exactly does it do?
So SHARPS, before the OP piece, was launched by Dr. Jason Newland and his collaborators many, many years ago. And I do want to acknowledge their contribution to just creating an opportunity for all people who are interested in pediatric antibiotic stewardship to actually come together to promote the safest, most effective use of antimicrobials in pediatric care. Now, in the summer of 2020, I was asked to present a webinar on our outpatient ASP efforts at Children's Mercy. And then right after, we realized there's a lot of institutions who actually wanted to do more in this space. So we connected with over 59 institutions to expand stewardship to outpatient settings, and SHARPS Up was born back then. Now, today, we have 22 institutions that share quarterly reports on prescribing patterns. So really, it's all about benchmarking and learning from each other to improve our outpatient stewardship.
That's wonderful.
Yeah. 22 institutions all collaborating. I love it. More data, more power. What population was included in your study, and what types of data were you collecting?
Yeah, so stepping back, knowing that 2/3 to 3/4 of the antibiotics given to children are given for respiratory infections, that's where we decided to focus. And so the population included was children, so anyone under 19 years of age, who were seen in outpatient settings at these 22 institutions, so emergency departments, urgent care, or primary care, and who had acute respiratory tract infections. And so that includes ear infections, pharyngitis, strep throat, sinusitis. And we collected them over the period prior to when interventions were happening, starting all the way back in 2019 and continuing through the benchmarking period where we were benchmarking against one another in 2023 to 2024 is sort of where the period of this study was ending, although our efforts continue. So that was the included population. And then in terms of the data we collected, for this publication, we had kind of two parts to the data. The first part was the patient level data regarding antibiotic use during those acute respiratory tract infection encounters. So the ages of the children, where they were seen, what antibiotics did they get, and how long did they get those antibiotics for. Additionally, to try and better understand what was driving improvement within this collaborative, we then also asked the 22 institutions to give us a little bit more information about what their activities had been during this period where we were benchmarking against one another. So that was more directed at the people doing the work as a survey.
Yeah, I just wanted to add that although we clearly emphasized acute respiratory infections, in our aggregated data, we did actually get all acute encounters. So we asked people to exclude any like a visit for a wellness check or like telephone visits, but all acute encounters were included. And then we focused much of our efforts on ARIs because those are the encounters that we know antibiotics are used commonly with, and there's a lot of opportunities. But for the study, we do also have the total of all the acute encounters included in there.
Yeah, thank you for pointing that out. That's key because there could be one practice that is giving antibiotics in 70% of all acute encounters, and that would be really notable. And another practice that was only giving it in 10% of acute encounters, and that would likewise be notable on the other side of the spectrum. And so that's part of why we collected those data across all acute encounters. That's exactly right.
That's great. Thanks for setting the stage.
So if I understand correctly, you were especially looking at amoxicillin and azithromycin prescribing for acute respiratory illnesses. Why those two?
All right. Just like Dr. Kronman said earlier, the data we collect is aggregated. We did that on purpose to make it simple on people to create the reports. But when you do that, you lose the ability to drill down to the encounter level. So we kind of needed some high-level markers of guideline concordant antibiotics. Since amoxicillin is essentially the drug of choice for most common acute respiratory infections like otitis media, pneumonia, sinusitis, pharyngitis, it kind of made sense for us to use it as a surrogate, if you will, of a first-line guideline concordant treatment. And then azithromycin, on the other hand, remains a very commonly used antibiotic in pediatrics, even though resistant rates among common respiratory pathogen is high, and it really has very limited indication in acute respiratory infection. I can essentially only think of pertussis and atypical pneumonia. So that's why we felt that it's a good surrogate to evaluate rates of non-preferred antibiotics, if you will.
Now that we know sort of the who, what, how, why, let's look at what the data actually revealed. So your team analyzed more than 32 million acute encounters. That is a huge data set. 21 million during the baseline, and then another 11 million during the benchmarking period. What did you learn from the types of encounters you were seeing?
So I think one big takeaway is literally the sheer number of acute respiratory encounters. When you look at our total, we had about 7.7 million of the 32 million acute encounters were all due to ARIs. That's about 24% of all visits in the ED urgent cares and primary care clinics. I mean, to me, that's huge and reinforces why acute respiratory infections should really be a top target for stewardship. Now, there's a lot of other things I can think about as I was thinking through the question. Although the study has been instrumental in understanding some ambulatory prescribing habits, to me, I think it also raised a lot of questions. For example, antibiotic prescribing per acute encounter and ARIs is higher in the urgent care compared to the ED and the primary care clinic. Is it because of the type of patients they see? On the other hand, amoxicillin index was lowest in the emergency room, where you'd think severity may be higher and you'd expect maybe more escalation to alternatives or broader antibiotics. I think the last thing that we learned is really that treatment duration may be an easy target to decrease antibiotic use.
So were there any significant trends in the antibiotics prescribing that surprised you out of this data?
Yeah, I'll say there were three key findings to highlight. The first was perhaps a surprise, which is that antibiotic prescribing went up during the period that we were benchmarking compared to the baseline period. Both overall antibiotic prescribing among all encounters, but also antibiotic prescribing among just those respiratory encounters. When we thought more about it, we realized, okay, well, it may just be that our baseline was artificially low because it included the period of the early stages of the COVID pandemic when there were many fewer infections out there. So that was a surprise. But then the two really encouraging findings that we had were, first, that antibiotic use choices seemed to improve. There was an increase in the amoxicillin index, which is the proportion of those respiratory infections that are getting amoxicillin as opposed to a different antibiotic. And that's the main antibiotic we should be using, so we want that to go up. And a decrease in the azithromycin index, which is the non-preferred antibiotic most of the time. So we want that to go down. Both of those things were great. Finally, we saw an increase in the use of shorter duration therapies, so 7 days or less. And there's been emerging data over the last handful of years that we really can get away with shorter courses of antibiotics for many of these infections, as short as 5 to 7 days in many cases. And so using those durations as opposed to a 10-day duration can cut in half our antibiotic use, even when we're still choosing to treat a given infection. So that was really encouraging.
Okay. And because the study found that while overall antibiotic use actually increased during the benchmarking period, antibiotic selection improved, and you saw, more amoxicillin, less azithromycin, and shorter durations. So, in other words, prescribing might have gone up, but the choices got smarter. Is that what I'm hearing?
That's exactly right.
That's like saying that people are eating dessert, but they're picking the fruit cup instead of the cheesecake.
Yes, I like that analogy. It's stewardship portion control.
Right.
So let's talk about how those choices were guided. So the benchmarking reports, who received them and how did institutions actually use that feedback?
Yeah, it was variable. That's the short answer. So each institution got to do with it what they thought was going to be the most effective. The benchmarking reports went to the primary contact at each of those 22 centers. And then from there was disseminated often, almost always, to the Antimicrobial Stewardship Committee. But sometimes it was to the committee and frontline clinicians, At other times, it would go up to leadership of the institution in about a quarter of cases, and to other organizational committees such as pharmacy and therapeutics in about a quarter of cases. So it really was variable depending on the institution. But what I thought was really great was that institutions could widely disseminate these and really try and get the information into the hands of system leaders who could help better understand the importance of the data and also try to help continue to drive improvement.
And did those facilities offer you feedback? Did the participants find the reports helpful? And did any, do you know of any process improvement works that came out of those benchmarking reports?
Yeah, we actually surveyed all the participants on the impact of the benchmarking reports and what interventions were added as a result of the collaborative reports. I actually want to boast about the fact that the survey was completed by 100% of participants.
That's
For those
fantastic.
of you guys who do surveys, this is not easy.
No.
But the vast majority, 82%.
That is impressive, yes.
It's usually like 20% or something.
I can be quite persuasive with my emails, so it was pretty cool. But yeah, the vast majority, over 82%, said yes, they agreed or strongly agreed that the benchmarking reports were useful. And we had it opened for comments where you can put in whatever you think. And in comments on the usefulness, they mentioned the ability to compare to peers, which essentially in the outpatient ambulatory, the ambulatory antibiotic stewardship world, is really not available for us. For inpatient ASP, we have some measures we can use to see where we would be expected to be in comparison to others. But in outpatient settings, we don't have that. So we used to create reports initially, and people didn't know where they are supposed to be. I mean, what is a good amoxicillin index, or what is a good percentage of use of antibiotics for ARI? But then when you see that you are way above the rest of the country or way below, it kind of really helps. We also had about 40% say that they launched new initiatives because of the reports. And when we kind of looked at themes of what type of activities they did, they really fell into the CDC's core elements of outpatient ASP, of education, tracking, policy changes.
Part of what we measured was very similar to a new HEDIS measure called the AXR, the proportion of respiratory infections that receive an antibiotic. And as Rana was saying, we don't know what is the best target for that number. It shouldn't be zero. There are kids who should receive antibiotics, but it's sort of like a game of limbo. How low can we go? And what our benchmarking data allow us to do is to say, hey, great, Children's Mercy, Rana, is doing so well, and they're at 15%. And, we in Seattle are at 85%. I'm making these numbers up, of course. But then I'd be able to say, wow, look, she's getting such good outcomes and doing so while using such a low amount of antibiotics. I must be able to get closer to where she is. And that's why benchmarking can be helpful in the context of not knowing the exact floor of how low we're trying to get to with an antibiotic rate.
How low can you go? Can you go? I like this little limbo party we're having. So you also surveyed participating institutions about FTEs, or full-time employees, and staffing. What stood out about how facilities were resourced or not resourced for antimicrobial stewardship?
Yeah, I'll make 2 points about this. The first high-level point is, wow, is it variable? I think we, meaning society, we don't know what is the right amount of staff support to have people give or provide at a system level to ensure that we're doing this work optimally, because we're seeing there's such variability. So there's not a great benchmark for that in many regards, interestingly. The second point is that, encouragingly, there has been an increase in the amount of support for this work since it was previously surveyed a handful of years before this study. And that's great because, as Rana mentioned at the top of the show, 85% of antibiotic prescribing for children or more occurs in the outpatient setting. And so we really should be focusing attention here. And it requires physician attention, pharmacist attention, data analyst attention, and others. And so it was really great to see that more places are putting more effort here into outpatient antibiotic stewardship.
It sounds like there's some pretty significant insights here. let's turn to what surprised you the most once all the data started rolling in. The study noted that antibiotic prescriptions increased for acute and ARI encounters during the benchmarking period. I can't talk clearly. Were you surprised by that finding?
I honestly was not very surprised. Just like Dr. Kronman mentioned earlier, the benchmarking period did include COVID-19 pandemic. And then we had a substantial decline in antibiotic use in both pediatric and adult hospital. This likely artificially lowered our baseline metrics, but also in the later period, there were reported increases in invasive and non-invasive group-based strep infections in late 2022. We also had the triple-demic in the winter of 2022-2023. This is, for those of you who don't remember the term, the increased rates of RSV and COVID and influenza. So I believe these may have contributed to fluctuations in the rates. And as we continue to benchmark, we'll be able to see if this is a sustainable increase that continues to increase over the years, or if this was a peak and it's coming back down.
Well, then let's dig into strategies. Which ones do you think had the biggest impact and why? Why do you think that was?
This is the best part of the study, right? In our study, we actually found that guidelines, electronic medical record features, and quality improvement projects were associated with the lower odds of antibiotic prescribing, higher amoxicillin index, and lower azithromycin index in most settings. I'm honestly not very surprised by this. Systematic reviews of antibiotic stewardship interventions had showed that guidance and toolkits may have the largest impact in hospital, and EMR changes have been reported over and over again to be superior to education alone on improving quality of care. Now, as a QI passionate, quality improvement commonly incorporates education, engagement of frontline clinician, and EHR changes. So it kind of makes sense, and I was very pleased to see that they would be impactful and sustainable. I really believe that frontline clinician involvement is probably the biggest player here, because in ambulatory ASP, that possibility of a direct in-time feedback is not there. So you want to rely on the culture change. And what better supports culture change than having a frontline clinician lead an ASP-related QI project, I think the one thing that surprised me was that individual prescriber antibiotic reports was not found to be as impactful in our study. Since they're complex and quite time-consuming, it actually makes sense to pivot towards less complex intervention if time and FTE are limited.
So based on what you observed with the use of all of those different tools, does it seem like a multifaceted approach leads to a better, greater success in this realm?
Yeah, it sure seems that way. And as Dr. Feghaly just said, there are certain approaches that are time-tested and known to be more effective. Changing features in the electronic medical record to have a speed button or a preference list that just makes it easy to do the right thing, meaning to use a narrower spectrum agent or a shorter duration, in combination with education around that and feedback and so on, really can cement that practice change and that culture change, which is really hard to achieve. Additionally, these, with 22 locations across the country and with at least 3 or up to 3 practice sites at each location, emergency department, urgent care, primary care, those are not homogeneous places. They are all different, and different features of the intervention may help one of those places more than another. Just as an example, penicillin allergy delabeling. So to focus on that for just a second, we know that around 90% of children with penicillin allergy labels don't truly have a serious penicillin allergy. However, when that's on their chart, then they don't get the recommended first-line agent. And so there's been a lot of work recently to try and walk that back and remove those penicillin allergy labels where they're inappropriate. But that's not the kind of thing you're going to do in the emergency department. You don't have the time in the emergency department or urgent care. So that type of intervention will work much better in primary care. And that's just one example of how multifaceted interventions really will help provide the different kinds of tools for the different settings that we're trying to fix across this whole system.
It makes a lot of sense.
It does make sense, yeah. And I was struck by how much patient and family expectations can shape prescribing. I was struck by it, but I'm not surprised by it, if that makes sense. Yeah. Do you think parent pressure to just get an antibiotic still influences those stewardship efforts? And were there any education campaigns aimed at reducing that? I guess when I say I'm surprised that it still happens, because I thought we had a lot of education out in the public now, and we know most of those upper respiratory illnesses are caused by a virus, blah, 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 blah. So I guess I was struck by how much those expectations are still around. So let's talk about that.
Yeah. Oh, it's so fascinating. And in the next 3 hours, what I'd like to highlight is, there's so much there. I think the short answer is yes, those pressures exist. The long answer is a lot more complicated than that. So sometimes those pressures exist truly from the parent, the patient, the family. Sometimes the provider perceives that desire for an antibiotic, even when it's not actually there. Rita Mangione-Smith, a colleague of mine here, has shown that in the past. And when providers think that there's an expectation for an antibiotic, then they prescribe an antibiotic, again, whether or not the family really wants one. But all of this is in flux, as you say, as we have learned more over time about some of the adverse events that are attributable to antibiotics, and being better able to describe those risks of antibiotic use. That changes the risk-benefit landscape and how much parents really want that. There are some good tools out there to help providers communicate best in terms of trying to get parents to be on board with not using an antibiotic when one is not indicated, yet still feel satisfied with the visit and feel like something good came out of the visit. And I think whether or not those kinds of tools were provided site by site is really dependent on each individual site, but they do exist out there. One of the ones that I got to be involved with regarding that in the past was called the DART study, published in 2020 in Pediatrics, which helped kind of identify some of those communication behaviors that providers could use to diffuse the situation and not prescribe an antibiotic, but maintain patient and parent satisfaction.
Yeah, because I think it, as a patient or even as a parent, I think when you go to seek out a clinician because you're not feeling well, I think that there is some expectation that you're going to leave with some sort of resolution, right, to the issue. And I've been both a patient and a parent who has, been to clinical care for one reason or another, and the child ear infection, me suspected sinus infection, and left both times without an antibiotic. And actually, there were recommendations about other things that we could do to move forward and feel better. And actually, I was I was actually surprised and a little bit excited that it wasn't the jump to the antibiotics. And both of the situations resolved successfully, not in a significant amount of time. And so it was actually I felt very positive about the interaction. So I think, hopefully other people will have similar interactions and realize that maybe the antibiotic isn't always the answer, but there are other things we can do.
It's wonderful to hear. And I'm hoping Dr. Feghaly will talk about some of the cultural aspects as well, because that's what I was about to say.
To vouch for the DART approach. I don't know if you guys are familiar with it.
No.
But Dr. Kronman was involved in this. It's amazing. They've done a huge amount of work to understand what's the best approach to approach a patient and their family when they're coming in expecting an antibiotics, and what's the best approach to communicate that with them, that you actually do not need the antibiotics. And they come out with these excellent 4 steps of one. And I do it when I moonlight in the urgent care, even when I'm in an ID clinic and I see a patient who does not need antibiotic, I do this. As I'm reviewing the physical exam, I will tell them the ear looks pristine, no ear infections. The lungs are fine, no signs of lung infection, right? So you already are preparing to the thing that there's now no bacterial infection that's there. And then you deliver the diagnosis. You say, well, your son has a really bad case of common cold, like of cold, it's really bad. These are the things you want to do, and then you approach it on one hand, and you always start with the negative first, and then I always use on one hand, so I'm not interrupted because they know there's an on the other hand coming, right? So you say on one hand, antibiotics are not going to treat a virus. On the other hand, these are all the things you can do to help your child feel better, because that's what the parent wants, is feeling better, right? And you can give them everything you can come up with, that will help with their symptoms. And then you always finish with giving them something to come back to you if things are not working, right? So if you're not feeling better within 48 hours, call me or come back to see me. And when you approach it in these 4 stepwise approach, they have found that patients go like the parents go out even without antibiotics and are still satisfied. They're still, happy, and they're not going to argue over and over again with you to get the antibiotics. So I'm a huge fan of the DART approach, and I teach it to everyone I know, and I use it on my own encounters, and it's great.
I just was going to say, at first, that was a masterclass by Dr. Feghaly. Second,
yes, it was.
I want to highlight her for a second. One other aspect to this, which we don't have time to unpack fully today, is the cultural aspect and the language of care aspect, and also the aspect of systemic racism and unconscious bias. We know that certain populations are more likely to get antibiotics and to get broad spectrum antibiotics, and those tend to be the populations that are more societally advantaged here in the United States. So white children tend to get more antibiotics and more broad spectrum antibiotics than their Black or Hispanic counterparts in the studies that have been conducted. And Dr. Feghaly, along with Dr. Melissa Day in Cincinnati, have been leading a study to try and understand this process, to unpack it. Just yesterday, she was leading a session we had with family advisors who were talking about some of the cultural aspects of wanting an antibiotic based on their countries of origin and practices there, and the availability of just taking an antibiotic off the shelf and not needing a prescription for it. So there's a ton more to unpack and to learn for how we can get better in this that Dr. Feghaly is leading.
Please publish that so we can interview you on that again.
Yeah.
And thank you for bringing that forward.
Yeah.
That's a really interesting topic. And I wanted to mention, and correct me if I'm wrong, I don't think you said it, the DART approach stands for Dialogue Around Respiratory Illness Therapy. Is that correct?
That's exactly right.
Okay. So if our listeners have any curiosity about that, go Google it. It's pretty cool.
Awesome.
So what's next for the Sharps Op Collaborative? Are there plans to expand or maybe explore causal studies or randomized control trials to see which interventions move the needle the most?
Oh my God, I have so many things that I want to do. But the first thing that we actually started the work on is a new collaborative. So if you will, it's Sharps Op 2.0. It's called Aspire, and a microbial stewardship partnership to improve reach to everyone. And in Aspire, we are going to uncover a few things that we were limited with Sharps Op. One was because in Sharps Up, we were limited with the encounter. We didn't get encounter level data. They were aggregated data. So we couldn't really dig deeper into questions as to why was the amoxicillin index low? What alternative diagnosis may have been at play? What other antibiotics were used instead of amox or azithromycin, right? So now with Aspire, we are actually collecting encounter level data. We have 30 institutions that have committed to be part of this. We're already started getting the data from, I believe, about 20 and finishing up some data use agreement and IRBs with a couple others. And all of the data we're collecting is de-identified, but it is encounter level data. And not only are we getting the antibiotics that are used, the duration, the diagnoses, but we also are getting information on race and ethnicity and language and insurance and childhood opportunity index. So we can kind of dig a little bit deeper into why we see disparities in outpatient antibiotic prescribing. And the next phase in Aspire is to do an implementation science approach to actually try and decrease these disparities. So not only will people be able to benchmark against other institutions like we already do with Sharps Up, but they will be able to also address some of these health disparity equities and be able to dig into their data a little bit more so they understand what is happening and why and how we can approach it. So I'm super excited about it. We already started it. We started the webinars. The benchmarking piece is happening very soon. The dashboard is in progress and will be ready. And the also other difference is that this will be a dashboard, so you can access it whenever you want, as opposed to having a report sent to you on a quarterly basis. So it's a little bit more in depth, a lot more work on it, but it's very, very exciting.
That is amazing. It's amazing to hear that there's such a large scale collaboration that's going to shape the future of research. So let's bring home today's podcast with some takeaways. So for listeners who might be working on smaller or those resource limited settings, what is maybe one actionable takeaway that they could do tomorrow to strengthen outpatient stewardship?
I guess I can take that. I was going to say, based on our findings, since creating guidelines, changing some features in the EHR, and if you're able to do a QI project, have been shown to be the most likely to be associated with improved prescribing, if you will. I would try and do that. But for you to be able to do any of this, I think the first thing is you need to look at your data. You cannot fix anything. I always like with my QI, this is kind of like a thing I repeat every time. You cannot fix something if you don't know where you are. You want to start with looking at your data and seeing where you fall. But now, thankfully, you can have some benchmarking metric. You can compare to others and see, okay, well, this is where 22 other institutions nationally are. This is my amoxicillin index. It's only 50%. Or this is my azithromycin index. It's 30, when the vast majority of institutions are getting away with less than 5%, right? So then that will help you kind of understand where the problem is and what is the area of that you will benefit the most from working on. That is essentially what I tell everybody, that when they're just starting with our outpatient ASP efforts, start by getting data. And talking about data, I cannot have ever done any of this. None of us could if it weren't for our amazing data analyst, Dr. Brian Lee. He created the reports. He analyzed the data. Without him, Sharps Up would not exist. So I do want to acknowledge him. I offered for him to come, but he likes to remain behind the scene as our soldier who's doing all the work. So I just want to make sure we acknowledge him. I don't know what I would have done without him on this project.
Yeah, good shout out. There's always behind the scenes people that are lurking there, and they need their acknowledgments.
Absolutely true. And yeah, Brian Lee is well worth commending. He's absolutely the heart and soul of the work. I just was going to add two quick other easy things people can do in addition to what Dr. Feghaly was just saying. These are more in that communication aspect of everything. So first, she's already gone through in detail the DART communication practices. That's one thing people can quickly learn and adapt. And then secondly, they weren't shown to be tremendously helpful in our study, but commitment letters, just posting a commitment to say we're going to use antibiotics when they are more likely to do help than harm, and we'll avoid them where we can, and having that posted in your waiting rooms, in your clinic rooms, that's been shown to really help set the stage to set the expectation that we won't be using antibiotics a lot of the time. And draft posters are available at the CDC website that people can download and customize for their own location, including their signature, their picture, that kind of thing. So that's a quick, easy win that practices can do as well.
And I was going to offer that if anyone is interested in creating an outpatient ASP program, or they want to start and they don't know where to go, I will speak for myself and all of the people on on our collaboratives. We would be happy to talk to you. We'd be happy to give you all the insights we can. So just reach out. We're a small community. We love to support each other. As you can see, our collaboratives, all these people were, eager to do something to improve our outpatient ASP prescribing. And if you want to start, even if you don't know where to go, just reach out. I'll be happy to set up a meeting and chat with you about what we can do together.
That's awesome. Thank you.
Yeah, that's good to hear because my last question to you was going to be, what is your advice to clinicians who want to make stewardship part of their everyday culture rather than just a checklist item?
You need to start somewhere. You just need to start, Nicki. That's all it takes. When we first started, all of us in our outpatient ASP journey, we just had to start somewhere. And sometimes you pick up a small project and it's successful and you get frontline, clinician buy-in. And then when they see that they can improve care, then they get super excited. I think for me, I always use Children's Mercy because this is where I've been. I mean, we have an advisory board of urgent cares and ED and primary care docs and pharmacists and patient and family, and they give us, their feedback. But I think the only reason we've been successful in our outpatient ASP efforts is because I have stewards in every location. I have frontline clinicians who are actually doing the work, and they are the ones that are making the biggest impact. Without them, I don't think I would have been at all successful in my efforts, because you're more likely to listen to a colleague than you are to listen to an ID doctor who's coming from, they don't know your environment, they haven't worked with you, and they're coming to tell you what to do. But if your colleague who works with you day in and day out tells you, hey, you can reduce your duration to 5 days, you don't need to give 10 days for all these infections, they're much more likely to listen to you, right? So I feel like that is, to me, my biggest pride is that my frontline clinicians have been so engaged in outpatient ASP that it's becoming second nature to them. They choose QI projects even without me being involved at this point that are related to outpatient ASP. And that's amazing.
That is amazing. Well, thank you both for being here with us today and this incredible discussion around this awesome work that you've been doing. I think this study really underscores that benchmarking alone doesn't solve everything. But when you combine data transparency with guidelines, the EMR nudges, and QI projects, you start to see a real change.
Absolutely. I love that this collaboration didn't just track numbers, it built a national community of pediatric leaders that are determined to make smarter antibiotic choices. And to our guests, Dr. Feghaly and Dr. Kronman, thank you both for joining us and proving that good stewardship is as much about collaboration as it is about data.
And to our listeners, remember, antibiotics are powerful tools, but they are not party favors.
Amen to that. All right, and that's a wrap. Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.